Welcome to this case-based study of the pediatric cardiovascular system, focusing on congenital heart disease, a management-focused case. We are introduced to baby Achini, a 4-month-old female. Her mother reports that the baby turns blue and goes limp during crying episodes, a symptom that has worsened recently. Consider the differential diagnoses and what additional history is needed. Reviewing the detailed history, we note mild cyanosis at birth and poor weight gain. The cyanotic episodes, or TET spells, are triggered by crying and straining, resolving when the mother holds the baby with knees tucked. Discuss which features suggest cyanotic versus acyanotic heart disease and the mechanism of the knee-chest position. The physical examination reveals key findings: SpO2 of 75%, central cyanosis, clubbing, and a right ventricular heave. Cardiac auscultation shows a harsh, grade 3 out of 6, ejection systolic murmur and a single-second heart sound. Interpret the murmur's origin and the significance of the 75% oxygen saturation. Investigations confirm the diagnosis. The chest X-ray shows a boot-shaped heart and allogemic lung fields. The ECG shows right axis deviation and right ventricular hypertrophy. Echocardiography confirms a large VSD, overriding aorta, and severe right ventricular outflow tract obstruction. The diagnosis is Tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart disease, characterized by 4 features: a VSD, an overriding aorta, RVOT obstruction, and RV hypertrophy. The severity is driven by the dynamic RVOT obstruction, which acutely worsens during a TET spell. Acute TET spell management is a priority. The steps include positioning the baby knee chest to increase SVR, administering oxygen, giving morphine for sedation, providing volume expansion, and, if refractory, using phenylephrine or propranolol. Surgical management involves either palliative care via a BT shunt to increase pulmonary flow or definitive complete repair, typically between 3 and 6 months of age. The choice depends on the patient's stability and anatomy. Long-term follow-up is lifelong. Key monitoring areas include cardiac function, watching for pulmonary regurgitation, RV dilation, and arrhythmias. Preventative care includes endocarditis prophylaxis and transition to adult congenital heart disease care. The key takeaways are that Tetralogy of Fallot is a common cyanotic CHD. TET spells require a stepwise management approach. Definitive repair is standard, but lifelong monitoring is crucial due to the risk of pulmonary regurgitation and arrhythmias.